Okay, everybody. So we got next week, and that's it. And then we are done with the class. So hopefully by Friday, next Friday, we will have a test. We'll be all wrapped up, and you'll have till Monday to get everything turned in. So anyway, let's keep going here. The nice thing about these things being recorded is you can go back and listen to the other ones. Okay, so we talked about partial pressures. We talked about gas solubility. All right, we talked about um, how some gases are, like carbon dioxide is just way more soluble than oxygen is. But we also talked about the partial pressures, how up in here, oxygen tends to have higher partial pressures. Well, as this goes, if the internal and external respiration, due to the ratios of solubility coefficients and pressure gradients, equal amounts of gases are exchanged, right? So we have higher pressure of oxygen but lower solubility, and we have super soluble carbon dioxide but lower pressure. But what results is that there's equal amounts of these gases that are exchanged. Okay, so it's not like we more readily do oxygen than carbon dioxide. We have to do that equally, right? Because if we are going to look down here in cellular respiration, if we're going to take in six oxygen, and it makes six carbon dioxide and water, we need to be able to get rid of that much. If we take in six and only get rid of four, we're going to have an accumulation of carbon dioxide. That's going to be an issue, right? That's a waste product that we don't use carbon dioxide. All right, so yes, the pressure of oxygen is higher than carbon dioxide, but the solubility of oxygen is way lower than carbon dioxide. And so what we see here is the pressure is increased to drive oxygen in, and the pressure is lower, but the carbon dioxide is more soluble. So what we have is equal amounts of gases are exchanged, right? So when this whole thing, we have six oxygen go in, six carbon dioxide are coming out. So six are coming in on the blood, six carbon dioxide is going out on the blood. Oxygenated blood, deoxygenated blood. Okay? Now, that's intelligent design, right? We have two gases that aren't the same solubility. And so, therefore, the body, the physiological mechanism for respiration, increases partial pressures to make up for the solubility difference. That is intelligent design. That is amazing stuff. All right? So, that's another part of this whole internal and external respiration is that we have equal amounts of gas, oxygen, carbon dioxide exchanging. Okay? All right, I beat a dead horse. Okay. The thickness of the respiratory membranes. Okay, another thing that influences this internal and external respiration, not only the pressure gradients and the gas solubilities, but also now the thickness of the membrane. All right? If we get a thickening of it, that's going to be harder to get air to pass through, right? So swollen tissue can be caused by congestion and pneumonia, right? So therefore, that messes with the diffusion, that messes with the ability for oxygen to cross the membrane. All right, so that only makes sense. All right, so the thickness normally is a half to 1 micrometer, right? If we start to get a swelling or thickness of this membrane, that is going to hinder diffusion, which is going to cause us to have not enough oxygen, oxygen deprivation, which we call hypoxia. Okay? So there's another thing that can affect this whole thing. Okay? Swollen tissues, respiratory membranes, all these different things can keep stuff from getting into them by diffusion. All right, so now when we talk about the other things that influence internal and external respiration, surface area, right? We talked about the huge amount of surface area that is involved with the alveoli and all this, right? So 50 to 70 square meters for gas exchange, okay? emphysema or cancer, where the walls of those alveoli break down, that is less surface area for gas exchange, right? Or if we have a tumor growing in there and something happens, right? And we've cut down on the amount of alveoli that they're getting compressed, they're not able to, whatever it would be, right? When we start to mess with that, that's going to affect external respiration. That's going to affect how much air is able to diffuse into the blood vessel, or how carbon dioxide is able to diffuse out of the blood vessel into the alveoli, right? If we have emphysema, if we have a breakdown of those walls, less surface area, that's going to affect exchange. Okay? So there's quite a few things here, right, that affect this, right? We've got these partial pressures, see what I mean here? We've got high pressure of oxygen in here, low pressure of carbon dioxide. These are going to normalize, and you're going to have oxygen driven in, carbon dioxide driven out. We're going to have that exchange here where oxygen is driven into the tissue, carbon dioxide is driven out. Now we have deoxygen. Okay, we have that. We have that equal amounts of gas are exchanged. Okay, we have the thickness of the membranes, and we also have the surface area. You decrease the amount of surface area, that's going to affect that. You mess with the membranes, you make them thicker, whatever, that's going to mess with that. All right. Now, when we get into control of respiration, there's certain things that control that, right? And so we know that the nerve pretty much controls everything, but we also had two different types. We had the somatic and we had the autonomic, right? We had the sympathetic and the parasympathetic. Well, anyway, that's part of the autonomic. But right, the autonomic is the automatic, okay? So we don't think about breathing. It is done. The only time we think about breathing is if we're trying to hold our breath when we're going underwater, or if we're blowing out a candle. Other than that, we don't really think about breathing. It just, when we start being active, our respiration rate just goes up, and we don't have to think about speeding it up. Okay? So the phrenic nerve and the intercostal muscles and intercostal nerves transmit the impulses to the respiratory muscles. All right? So irritation of the phrenic nerve is what's responsible for a hiccup. What a hiccup is, it's a spasm of the diaphragm muscle. Okay? So that phrenic nerve is a cranial nerve. All right, so neural centers are located in the medulla and the pons. We talked about that. We talked about how brainstem injuries are what are lethal. Okay, we talked about head injuries, gun shots to the head, up into the upper area of the head. People live through those because up there they're not doing these vital, regulatory, life-sustaining controls, which are done in the brain stem. Okay, so the phrenic nerve and the intercostal nerves transmit the impulses to the muscles that run the respiratory. Irritation to that phrenic nerve is what you call a hiccup. Okay, that's a spasm. All right. Now, when we talk about respiration rates, okay, normal respiration rate is 12 to 15 breaths per minute. Okay, and so they call that eupenia. I gotta think about this. Eupenia. How do I can't? Anyway, now it's on forever for YouTube. Anyway, that's normal respiration rate, 12 to 15. All right. A higher than normal rate. I gotta think about how to say that. Apnea. Here's apnea. Hyperpnea. That's a higher than normal. Apnea is no breathing, right? So when you talk about sleep apnea, what's happening is that people are sleeping and then all of a sudden they just stop breathing, and then they will restart and their brain will kick in, and then they'll be gasping and snoring and all that kind of stuff at night, and that's hard on the cardiovascular system and starving yourself of oxygen, that kind of stuff. You don't want to do that, right? Apnea, dyspnea is general term for the abnormal rate. All right. So if we are abnormal, we have dysfunction, dyspnea. Man, I can't say. I can't talk. So physical factors, conscious control. These are all other things that will run rates. Okay. So normal, too high, none, just a general abnormal. It ain't right. Okay, fast, slow, no, it doesn't matter. They're going to say it's this, and then they'll qualify it as one of these. Okay, so different physical factors can influence this respiration rate. Conscious control, emotional factors. You get bad news, or you get super nervous, or whatever, and people start hyperventilating. Okay, chemical factors. Um, um, all these different things can influence the rate and the depth of breathing. Okay, so there's a bunch of different things that can do this, and a lot of that is monitoring carbon dioxide levels, monitoring oxygen levels, monitoring pH, all these different things, and they can increase or decrease a respiratory rate. So you guys will get a kick of going back and listening to me talk about eupnea and hyperpnea and apnea and dyspnea. Anyway, I can't even say it. Anyway, so laugh it up, funny people. Anyway, so hyperventilation. Okay, hyperventilation. We've heard of this. It's deep, rapid respiration, and there's too much carbon dioxide is vented out of the body. All right, so you start breathing heavily and quickly, and carbon dioxide is you're getting rid of too much carbon dioxide. Okay, and remember, our body likes homeostasis. We like to stay within a nice little narrow margin. Okay, but so what ends up happening is if we get rid of too much carbon dioxide, then we're not getting enough acid production, and it's going to mess with our pH. Okay, so now we're not. If we have less acid, then we're going to end up being basic alkalosis, right? So when we're too basic, one of the things that you do is that you take and you trap the carbon dioxide and you rebreathe it in until the breathing returns to normal, all right? So it's not magic. The paper bag has nothing magical about it. But what it does is it reintroduces a higher level of carbon dioxide, and it's going to get more of this carbonic acid to be produced, going to take you out of respiratory alkalosis and allow that respiration rate to return to normal. Okay? Now, hypoventilation is where you have this slow and shallow respiration, and so it's not getting enough carbon dioxide out. All right, so now we have the opposite problem. Now, with not getting enough out, now we have too much acid, right? Too much acid. We have too much carbonic acid, and respiratory acidosis results. Okay. Normally, when we see something like this, or we can't get the carbon dioxide out, we're looking at something like COPD, chronic obstructive pulmonary disease, asthma, obesity, trauma, pneumonia. Okay, something's going on in the lung. These are many different things that are causing the lungs to not be able to expel the air like it should. So they would say, if your breathing is shallow and slow, they're going to say that you're in respiratory acidosis, which means you're not blowing off enough carbon dioxide. Okay. So let's get into a few. Of these disorders. Okay, this is what everybody likes. Everybody likes this. Yeah. Okay, chronic bronchitis. Okay, so we have inflammation of the mucosa, and we have a chronic mucus production. All right, so not only do we have the swelling of the wall of the bronchioles, the bronchi, but we also are having an excess amount of mucus production. All right, so the airway is smaller, and then also it's packed full of mucus. Okay, so it's obstructing the airway. Okay, so it's kind of a double whammy. So this is a chronic thing. And so this is not acute infection. This is somebody that struggles with this stuff all the time. All right, and so when we look at this, this is a normal airway. Okay, and then when we get into this and we see bronchitis, we see garbage and not a very smooth um, not a very smooth pathway. We see mucus that's in there, and so anyway, you can see how nice and clear and open that looks, and how cruddy that looks. All right, so the big thing with chronic bronchitis is the mucosa is inflamed, right, and it cuts down on the area that air can go through, and also we have a bunch of mucus that's produced. Okay, so not only even just mucus alone would cut down on some of the airway. However, now if you have more mucus and then you make the area smaller, now you've really cut down on the airway. Okay. Now emphysema, breathing is very labored due to lack of alveolar recoil. All right. So you have to work to get the air out, right? So the recoil is when it stretch and then it goes back. Stretch and returns. Stretch and recoils. Stretch and recoils. Well, imagine blowing up a balloon and letting off of the end, and the air doesn't rush out. That's kind of what we're dealing with. All right. So when you do that and you inflate, you stress those alveolar walls if they don't recoil. So then sustained pressure is going to cause walls to collapse. And when walls collapse, they break down, and then that's going to lose surface area, and so we get less of this gas diffusion. All right. And the other part of it is that membranes tend to thicken, so they decrease the diffusion eventually, right? So you kind of got a twofold thing. You got alveolar recoil. You have balloons that are being blown up that won't blow the air out when they, all right, they blow up, but they won't shrink back down. And so that's going to mess with the walls and break them down, and you're going to have less alveoli. And over time, the membranes, with that sustained pressure and increased stress, the membranes will start to thicken, and that's going to mess with how much oxygen and carbon dioxide can pass. Okay? So, here we have healthy lungs, we have healthy alveoli, we have all these little air-filled sacs, we have all these membranes, we have vessels all around them, and there's diffusion going on. Okay? When people are smoking, then what we start to see is we see particles that are getting trapped in these delicate, air-filled, thin-walled sacs. All right, and so we have these little particles of tar or whatever you want to say is in there. So when you have this in there, that's an irritant. And anytime something's irritated, it's going to get inflamed. And once you get inflamed, then you're going to start to get a chronic thing going on. The membrane walls are going to thicken up. You're going to have and so you start to see these chemicals start to dissolve. They're trying to get rid of the garbage that's in these alveoli. But in doing so, the chemicals, the inflammatory chemicals that are dissolving this garbage or trying to, is messing with the alveolar walls, destroying them, and now we just have this big thing here and not all these individual clusters, and so we've reduced the amount of surface area by how many just in this one little example here. And what we end up seeing is the accumulation of this garbage, right? These harmful particles, the carbon, the tar, whatever you want to say, in the lung, and they are actually visible when you start to take and you dissect someone and they have been a smoker. It's pretty undeniable. Okay? So emphysema and chronic bronchitis they tend to have a smoking history. All right? People that struggle with chronic bronchitis tend to have a smoking history. And again, smoking, as evident by this picture here, is basically just a consistent, constant introduction of irritants into the lungs that the body's trying to get rid of, and in the process dissolves some of those delicate membranes and reduces the surface area. Okay? So chronic bronchitis is continued irritation by that garbage that you're smoking in, right? So then we have this dyspnea, dang it, air hunger, right? So something's not right due to the dysfunctional breathing. We have a lot of coughing due to the excess mucus production, due to the mucociliary ladder being an issue, and also we're going to see a lot of infections, right? If we have this stuff going on, we have this constant going on in here, we have a constant bunch of irritation in there, we're going to get some infections, all right? And eventually what's going to happen is you're going to get respiratory failure, you're not going to be able to get enough oxygen into the body, and also you're going to have this whole acidosis thing where you're going to have the difficulty of getting carbon dioxide in and out of the body. Okay, especially out. So lung cancer, basic info, a third of all cancer deaths are due to lung cancer, right? 90% have a smoking history. All right, so now, you don't want to have lung cancer? Then don't smoke. Okay? I mean, your chances are way down of having lung cancer if you're not smoking, right? I mean, anyway. So, a third of all cancers are due to lung cancer. Now, they metastasize very rapidly due to the vascularity of the lungs, right? When we go back in here and we look at this and we look at all these little individual sacs and we look at there's vessels, that's not what I want. There's vessels all around each one of those things. Then we're going to sit there and talk about how there's a lot of blood flow that's going through there. Actually, all your blood flow goes through there, right, to be oxygenated, right? So that's highly vascular. So we learned that a metastasis is a cancer cell that has traveled and then gotten lodged somewhere else. Well, if you get lung cancer, and how vascular it is, it's not hard for a little piece of cancer to break off and then go travel somewhere else. Okay? So here we see invasion and metastasis. Cancer cells invade the surrounding tissue, and then they get into the blood supply, and then they end up spilling out over there, and they reinvade and regrow in a new location. Okay? That's metastasis. Okay? So then Monday what we'll do is we'll start, how many more do I got? Holy moly. Monday what we'll do is we'll start, we'll do some more of these. Well, let me do a couple of these. So there's 3 types of lung cancer. Whoopsie. 3 types of lung cancer. Okay, they'll continue on the next slide. So we have squamous cell carcinoma, we have an adenocarcinoma, and we have an a small cell carcinoma. Okay, I'm not sure I'm really going to worry about what they look like. Okay. So the squamous cell carcinoma, it begins in the larger bronchi and the bronchioles. It forms in masses that have bleeding cavities with them, all right? So what we're going to do is, so we see here, the bronchi and the bronchioles, those are the right off the trunk of the tree and some of the bigger branches, right? That's where we're going to see these tumors, all right? And they form big masses and they bleed, they're vascular. Okay, and they have bleeding cavities within them. All right, so we see here lung field, and we see masses in this lung that's blood filled and whatever. Okay, again, in here you can see that just don't look right. Okay, so again, in the bronchi and the bronchioles, when we talk about an adenocarcinoma, there are nodules that develop in the peripheral areas of the lung. They develop from alveolar cells and bronchial glands. All right. So now, these aren't in the main trunks. These are out on the leaves of the tree. These are out on the outside, and they are from alveolar cells. And there's glands, bronchial glands. And then we have small cell carcinoma. Right. They originate in the primary bronchi. Right, the primary bronchi, and they grow into small grape-like clusters in the mediastinum, and it's very aggressive. You get this, and you're counting your days. Okay, So they're in the main bronchi, in the primary bronchi, the right and the left primary. That's where you'll see it. It grows quickly. It's aggressive, and it will really kind of get right in there in that mediastinum, which makes sense, right? Because those primary bronchi are midline, right underneath the sternum, and so we're going to see that in the midline. Okay, so the treatments for these cancers are cut it out, radiate it, and chemotherapy. Okay, so you want to cut that thing out. If you can take it out, you want to take it out. Don't give it any more chance to be throwing off babies into the blood supply, right? Then you're going to want to do radiation of that spot to make sure that you kill all dividing cells, right? Because we know that cancer is an out of control dividing cell. You want to kill all the dividing cells in that area, and then you would take a chemotherapy, which would be a global thing, to try and reduce or kill off any dividing cells that may have traveled out of the lung. Okay, so when you look at this, when you talk about cutting it out, here's someone who has had their thorax opened up. They went in there, they took out the spot, and sewed them back up. All right, so we're going to stop there. Make sure you understand this stuff. If you have any questions, let me know. We'll start back on Monday. I want to have the test on Friday. I want you guys to be done with this class on Friday. All right, you guys have a good day. I know you miss me. Talk to you later. Bye.